Welcome again to our EKG series. I'm John Felt, and I'm joined today by Dr. Andy King with the Michigan Region Poison Control Center. Thanks for coming, Dr. King.
Thanks for having me.
Absolutely.
You actually came to me.
I did, yes, so you're right. So we're going to be talking a little bit about toxicology and how it affects the EKG. So we'll kind of start out. I think you've got some stuff prepared for us.
A little bit. It's going to be a little bit of a discussion starting with the very basics, because most toxicologists think in terms of channels and receptors, etc. And so I think especially for the cardiac conduction cycle and how drugs affect that, it's important to understand like the action potential and the various ion channels that are being affected. Mm-hmm. I think today we're just going to focus on sodium channels and sodium channel blockade. So here's my little picture here. And I have not practiced any of this, so I apologize, but here's your general action potential, right? Mm-hmm. And from most of your cardiac myocytes, and then you have the different phases, right? 1, 2, 3, 3, and then 4. And when we're talking about the sodium channels, like the fast sodium channels are phase 0,
right?
And then that generally correlates to what you see on your EKG. So you got your P wave, and then your QRS is really what you see with the sodium channel opening, right? And then the QT, or really the JT, is what you get here. So the QRS is just really the width of this initial narrow complex, which is supposed to be narrow. When you think of your general cardiac myocyte and then the sodium channels really affect all components of it. So dronotropy, inotropy, and chronotropy, a lot of them are affected by the sodium channels. Mm-hmm. And then obviously when it's affected, you can be terribly sick, and then that's why you run into the general toxicology spiral of death, which is seizure coma death, right? That's what you always start with. And severe sodium channel blockade is definitely potentially deadly. And important to pick up on, because the earlier the treatment, the better, and there are absolutely good therapies that you could administer people. So anyway, let's give you an idea of what we're talking about here. Is when you're talking about sodium channel blockade, right, you're having, your sodium channel really exists in 3 different conformations. So the closed state, right, then the open state, when they're both open, and then the inactive state. And I think those are the 3. So this is closed, open, and inactive. And depending on the substance you're talking about, they can affect the different ion channels in different conformations for various periods of time. And some of that is broken down into the von Williams classifications, if you remember that.
Not
from
a
long time ago.
No.
No? All right, well, let's remember some of it. So you have the class 1, 2, 3, and 4. And do you remember how to remember these, or?
No.
Do you remember these at all? No.
So this is med school. This is a long time ago. Age, trauma, all of that.
So this is probably inappropriate, but you can, whatever you want to remember, whatever mnemonic you want to use to remember these different classifications. Right. But so the class 1 are really the sodium channel blockers, and those are broken down into A, B, and C. And again, it depends on if it's fast on, fast off, and then what conformation they're really affecting to sort of break them down. And the class 1A are generally your TCA-like sodium channel blockers, right? Quinidine, quinine, etc. B is your lidocaine, and then C has actually, I don't remember all of them that are in there, but
see, it's a long time ago.
It's been a long time.
Even for the
I haven't had enough coffee.
Remember.
And then type 2 are beta blockers,
right?
But those
vaguely becoming familiar.
You remember these? Yeah. But sometimes they can have other effects, right? So propranolol, for example, is a sodium channel blocker, so it's not just a beta blocker. Right. And sotalol is a potassium channel blocker, so it's not just a beta blocker. Although that's the primarily classification for them. And then you have your potassium channel blockers, right? And then people talk about amiodarone being one of the classic potassium channel blockers, and that's kind of, you think about QT prolongation, but amiodarone has lots of other effects too. So it affects the calcium, and it is a little bit of a beta blocker too. And then the type 4 are your calcium channel blockers, your verapamil, your diltiazem, your dihydropyridines, etc. So anyway, we're not really going to be focusing on these latter 3. We're going to be focusing on the sodium channel blockade today. And so when you have a drug that gets into the sodium channel, right, you're decreasing the amount of sodium channel that's coming intracellularly, and you're decreasing the slope or the depolarization slope of the action potential. So if you come back over here where the action potential is, and then you add a sodium channel blocker on there, sodium channel blocker, you notice that the upslope sort of decreases, right? And then you don't have really as high of an action potential. And then you can actually prolong this interval here too. So that's why always when you widen your QRS out, you are going to widen your QT because the QRS is part of the QT, right? So you have your QRS and then you have your QT. And if this widens out, of course, this whole segment's going to widen out. And then this really, honestly, after overdose, sodium channel blockade is the one that concerns me the most because that's the most immediately deadly and the one that you can deal with with antidotal therapy, for lack of a better term. The QT prolongation people get really excited about, and yeah, it's a big deal over a long period of time, or if it's super wide, or if they're going into torsades over and over. But generally, acutely, the QT is sort of less of an issue, unless, again, actively they're going into some sort of dysrhythmia. So for the sodium channel blockade, right, you have a molecule that's getting in the sodium channel and preventing sodium from, going extracellularly to intracellularly. All right. Action potential or potential sodium channel blockade, and then when you look at it at the EKG, generally you have like a narrow QRS, right? But again, when you're talking about the widening of sodium channel blockade, you're talking about widening of the QRS. So it starts looking like that, right? And I brought a case for you here that we'll take a look at the progression of the EKGs. This is actually a recent case of an actual TCA ingestion. It was disipramine in this case, but they all do the same thing.
Yeah.
So anyway, that's kind of what you're focusing on, and that's general pathophysiology behind that. And then so not only so QRS, right? Why do you care so much about the QRS being wide? Why do you care about the sodium channels being blocked? Well, we talked about the general things that affects in a cardiac cycle. So when you decrease the amount of sodium that's in a cell, right, eventually you're going to decrease the amount of calcium that's in the cell. And so if you think of sodium as your communicating ion, for lack of a better term, so depolarization happens and then that spreads throughout the myocardium, right? That's the quick, just like letting everything know that it's time to contract. And that's eventually coupled to calcium getting in the cell, which really is the thing that leads to the squeeze, right? So you think of this as your communicator, and this is your squeezer. And so when you decrease the sodium, you're actually decreasing the calcium. So you're decreasing inotropy, right? When you're decreasing the amount of sodium or the rate at which you get the depolarization, you're decreasing the chronotropy and the dromotropy, right? Dromotropy is the rate the spread of the signal throughout the myocardium. So all those things going down equal what?
No heartbeat.
Yeah, no heartbeat, right? So
That's
you get a wide QRS, and so generally the pre-morbid things that you'll see is like the QRS starts widening out, and then they'll become more bradycardic, and then you'll become hypotensive, and then all of a sudden you'll start running into dysrhythmias, and then death, right? And so looking at these, because TCAs have been around for such a long time, there's lots of experience with overdose of TCAs, right? And so we can make some prognostic determinations just looking at an EKG, right? They had looked at TCA levels in the past, but realized that that's not super great correlation to how they're clinically. And it takes forever, right? So. What can you do quickly and easily? Man, you can get an EKG. It takes 5 minutes, and you can get a lot of information from it, right? It's cheap and it's delicious and it's repeatable. It doesn't hurt anything, right? You're not poking anybody. You're not like wasting laboratory dollars. Right. And so, and this can tell you a lot of stuff, and it can help you prognosticate. So I'll throw a couple quick numbers out there. So again, we look at QRS, and they've looked at all the different EKGs and trying to come up with various aspects of the EKGs that can predict bad outcomes, right? So QRS is one of them. So a QRS of greater than 100, that puts you at risk for seizures and ventricular dysrhythmias. And so, and then I'll give the caveat that a lot of toxicologists and a lot of people will use different thresholds to decide to start treating with sodium bicarb, et cetera, right? So I'm just going to give you some of the textbook ideas, and then I'll tell you what I've been trained to do. But you'll see different numbers, so I don't want you to get confused or concerned when you're getting different takes on the literature. So when you talk about a QRS greater than 100, about a third of people are going to end up having seizures, and maybe 14% of them are going to have ventricular dysrhythmias, right?
Okay.
So that's a big deal. And then when you start talking about it being greater than 160, so our QRS, right, and we're talking about just measurement of the limb leads.
Yeah.
So limb leads, so once you get greater than 160, then you start talking 50% of people having ventricular dysrhythmias. And so that's not good, right?
No.
Ventricular dysrhythmias are unstable. You got to shock them out of it. It's just about dead time.
Yeah. That's when the shift becomes a bad shift.
That's right. Well, they become more exciting from my standpoint.
Well, that's
I really
true,
like
true.
those. All right, so that's QRS. So that's one criteria, the EKG. So literally you can just look at, as long as it's the limb leads, right? You can just look at the top of the EKG, which even an orthopedic surgeon can do, right? You just look at the top.
Come on now.
You can just read that number, right? And that
Yeah.
can give you a lot of information. Again, prognostication. And a lot of it is, clinically, how is the patient doing, obviously. So we're not just treating numbers. The other thing I'd throw out there is if they have a pre-existing non-specific intraventricular conduction delay or block, or if they had a pre-existing right bundle branch block, which a portion of the population does have, that it's hard to interpret, right?
Right.
It's kind of infuriating. Because one of the things that TCA can do is actually cause a right bundle branch looking thing, and even you can get a Brugada looking type pattern too.
Right.
So anyway, that's one of them. The other one is the very often overlooked limb lead, right? Which one do you never look at? Do you do a lot of EKGs?
Yeah, the AVL, I guess. No.
AVLs would be one. What's the other one? AVR, right?
Yeah, it's true. AVR always.
Nobody looks at AVR, but this
sitting
one
there by itself up on the top.
Yeah, we like to talk about this as being like the tox limb lead that we pay attention to, and I'll show you why. So
It's got to be popular with somebody, with the nerds, the nerd crowd.
How dare you? All right. So when we're talking about the bundles, right? You have your right bundle and your left bundle.
Yeah.
And then, it seems like the right bundle is much more susceptible to blockade by sodium channels, right? It's kind of thinner, and, I don't know exactly all the mechanisms, but that's the one that seems to be most affected. And then when you're looking at QRS complexes, and I'll show you this when we actually look at the EKGs, you'll start seeing that really the terminal 40 milliseconds of the QRS complex, instead of like getting like that nice, really tight, QRS complex, it's like the last part that gets a little bit lazy, right? So you get this really nice tight, and then it kind of it just takes its time, right, for the remainder of the depolarization. And then you're going to start getting this rightward axis deviation, this right bundle branch kind of looking pattern to it, because probably the right bundle seems to be more affected in general. So that's one of them. But when you're talking about AVR, we're looking at actually the usual limb lead. Let me see if I can go. Let's go down to the initial EKG. So you'll see here, and for demonstration purposes, because I probably have a hard time drawing it, but you see here, this is a pretty normal AVR looking complex, right? Do you know the first downsloping is of the QRS complex?
The Q wave.
The Q, yeah. So you get the
shocking.
Q, right? And then what's the up?
R.
And then the last down
I think it's
is
the S.
yeah, right? And so when you're looking at, I'm sorry, John.
That's all right.
It's not for you. This is for everybody else, right?
It is for me, too.
So when you're looking at AVR, right, we start paying attention to the ratio of the R to the S wave, right? And really, honestly, I'm really just looking at the R wave because it's easier. You don't have to calculate a ratio, etc. And so when you start seeing this R wave get bigger and bigger, that's when you start getting more concerned that there's a sodium channel blocking effect going on, assuming it's not a baseline thing. And so you can look, once you start seeing that the R wave here is getting greater than 3 millimeters, that performs about as well with prognostication as, at least with the older literature, as a QRS of 100, right, as far as predicting seizures and ventricular dysrhythmias. And the other thing you can look at is the R to the S ratio. If it's like 0.7 or more, then you're gonna have the same thing. So they all kind of perform that way. And so that's why it's easy. Instead of just looking at the QRS, you also want to look at AVR. And if both of those things look sodium channel blocky, you're like, well, maybe we got an effect here, right? Maybe we should start doing some serial EKGs and paying attention. Or the other thing I'd like to say is that maybe what they said they overdosed on is not actually what they overdosed on, right? 'Cause people can't tell the difference. You know how it is, right?
Right.
You just take all your medicines, you put them in a magic bullet, you blend them up, you drink them. I don't know what's in there.
It's good stuff.
It's like Jamba Juice of overdose.
That's right.
Anyway, the other thing, and the last thing I did want to say is that you can get a Brugada pattern. It's not super common, but remember you start seeing this kind of goofy looking thing in V1 through V4 or so. And that can last and persist and sort of be intermittent, so it's kind of a fun little aside there for you. There it goes. All right. So this scenario is a young lady who came in and she said she overdosed on Xanax, right? So they did the usual good old tox workup. Sorry, I'm trying to erase this. It's not doing a very good job. And so they got this EKG, right? What do you think about this EKG? Super exciting?
Not really.
Not really, right? Kind of boring. And she'd just done it prior to coming in, maybe like half an hour, right? And so remember with TCA overdoses, we like to, or if you're suspecting like just about any tox overdose, they should start manifesting something, with some exceptions, within the first 6 hours or so. And the TCAs is kind of where that literature originally came from, that you watch somebody for 6 hours, and if they're fine, then it's hasta la bye-bye. But if they start getting sleepy, or if their QRS widens out, or they become tachycardic or unstable, or have seizures, something clinically obvious, right? Then you should probably keep them and rethink, your ultimate disposition. So anyway, this is not a super impressive EKG initially, right? It's hard to get excited. I don't remember what they called the QRS, but you can see how many boxes do you think that is?
At most, maybe 2.
Yeah, something like that, right? And remember, we're looking at the limb leads, so don't worry about the precordial leads. You stay away from those. Okay. So they went back in and assessed her, and they noticed that she was getting like more and more drowsy, right? Like really kind of hard to arouse drowsy. And then so they started rethinking, right? Well, maybe this was not just a Xanax, because when they put her on the monitor, because she was getting more obtunded, they were trying to get a pulse ox. They looked up on the monitor and they saw a real wide complex, right? Yeah. And that started getting them nervous. So this is the first EKG they got afterwards. So what do you think about this?
This is just, like 2-3 hours after presentation?
Right.
Yeah. So this one, I see that you definitely have a widening of the QRS. So now we're out beyond 2 boxes, and then if I am looking at AVR, I think
you're starting to see the R wave is starting to get a little bit bigger, right?
Yep.
And a little bit wider, and you can see the terminal 40 seconds is getting a little bit lazy, right? It's taking its time. Like V5 would be a good example. Getting a little bit lazy. So here's another one. Here's the next one that they got after that.
This is about 40 minutes later.
Yeah.
So now, again, we're seeing just a progressive widening of that QRS, the R wave definitely becoming wider. Yeah. And then down in V5, you definitely see that.
And then here you go. Here's the money, right? And it starts getting real wide.
And so this was just after, I would say, about 2 hours after the first change in the EKG is when they started seeing this. So, this may be a time you change your underwear.
That's right. So you're really starting to see there's QRS widen out. You're starting to see AVR get big, right? And then you're seeing the terminal portion just be even more and more slurry. Now, this isn't as impressive as what they were seeing on the monitor, right?
Right, because it's amplified.
Exactly, right? So on the monitor, they were literally seeing sine waves, even with these previous EKGs. Right. It looked more like a sine wave, right? And they were starting to get Brady. And so they brought her back to the resuscitation area, put an IV in. No, she already had an IV in. But they started giving some bicarb, right? Yeah. And so almost immediately after the bicarb, the doctor told me that she had like a short run of wide complex tachycardia, and then she went to like a much narrower but bradycardic rhythm, right? Mm-hmm. And so they followed these for a long time, and eventually it came out that, again, she overdosed on a TCA called disipramine. Disipramine. Don't worry about the spelling. Can you edit that out?
I wouldn't even be able to.
Don't worry about that. Don't worry about that little guy right there. So anyway, she overdosed on disipramine. And so, the treatment for sodium channel blockade, there's a couple things. So remember, you have a blocked the ability for the sodium to get extracellular to intracellular is kind of blocked, right? And so some of the pharmacological ways that we overcome blockade are you just bring more friends, right? You're trying to get into a bar, right, John?
You just overwhelm the bouncer.
You just overwhelm the bouncer, right? Just like a big old bum rush. And so that's one way to do it. Right. So you can induce hypernatremia by giving
hypertonic saline.
Yeah, you do hypertonic saline.
Like the standard 3%, or are you going higher?
Oh, we don't pull out the hot salts right away. I'm just saying this is just like one theoretic way to do it. The other way to do it is like maybe whatever's blocking the sodium channel, maybe you want to get that guy off of there, right? And so one of the ways that you can do that is you can modify the pH. So by increasing the pH or becoming more alkalemic, right, you actually increase the protein binding of the TCA, right? So it's not sitting there, it's not sitting on that channel. Maybe it goes to sit on some albumin or something else, right? Just like not in the damn channel where you don't want it.
Yeah.
The other thing, it probably decreases, honestly, just the affinity for, the ion channel there by changing the pH, right? And so, they try to figure out, well, is it the sodium or is it the pH? And there's a whole bunch of, animal studies and guinea pig hearts and all that kind of stuff. And long story short, I'd probably say it's a little bit of both, right? You probably, by giving a bunch of sodium bicarb, you are giving a sodium load, so you are increasing the gradient. And then by giving a bunch of bicarb, you're obviously changing the pH, right? As long as I can breathe it off, obviously, you're changing the pH, and that's probably decreasing the binding. So you see an effect from both of those, right?
And how quickly? So in this case, they saw an effect pretty quickly. Is that common that you'll see that?
Yeah, in my experience, anecdotally, from what I've read and what I've seen, and then having done this a couple of times during fellowship, that it's pretty impressive, pretty acutely, right?
Okay.
So one thing I'd tell you is I had a nice Benadryl overdose, which can act like a TCA that people don't really realize. But she had done this a couple of times. She overdosed on Benadryl, and then she came in seizing, right? And I walked in. The ED physician was trying to push bicarb just based on the wide complex in the monitor. But I'd say as someone who's actively seizing, right, are you really going to control their pH with just bicarb alone?
Not so much.
So what do you think you'd want to start with in that case? You want to stop the seizure, right? Yeah, so you want to stop the seizure, so then that's going to help a lot with your pH, and then you can work on other things. So it'd be, in that particular scenario, it'd be, and that can happen with a lot of TCAs, is that you want to stop the seizure, the acidosis, because you're just going to be fighting against it until it does stop. Hopefully it self-resolves, but sometimes you want to try to stop it on.
So standard benzos and...
Yeah, right. So anyway, those are kind of big things. So we start with, when you're doing your treatment algorithm, so sodium bicarb is the way to start, and then you're just going to give, a couple of amps, right?
Right.
And hopefully
Pete's weight-based, but...
Yes. I don't know, man.
pH too high.
I just grab the vial and we just push it. But you want to start with bicarb, right?
Yep.
And then what do you think you're aiming for?
pH greater than 8.5.
This is a little high, so we usually like say 7.45 to 7.55. Really don't want to get too higher than that because you can start running into problems with, alkalemia. Proteins don't work very well in that range. So really, you're looking for a serum pH, right? And then you're going to start a bicarb drip, and then don't forget that when you're starting bicarb or when you're administering a lot of bicarb, you're going to run into hypokalemia is going to be a big issue. And if you already have some QT prolongation, you're going to see that you're going to be chasing your tail a little bit. And then you could do the hypertonic saline, right? So the 3%, whatever it is. And then, people will say you want to get your sodium up to like 150 or so, maybe 155 if you're feeling saucy. But really, you're going to see, if you check some serial BMPs, sodium bicarb is going to be a fair sodium load, so you're probably going to get there anyway without even having to try. Another interesting thing, kind of more of a third line, I'll write this down, and if you gasp, I understand. Lidocaine? Lidocaine?
Really?
But that's a sodium channel blocker.
Right.
Yeah, but it's one of the...
Competitive.
That's right. Yeah. So it's the type 1B, right? So when you break them down, lidocaine is in this area. And it doesn't really affect the QRS complex. And the idea is that you're given lidocaine it's competing with the sodium channel. This is the theory that it's competing with it. And then maybe you're not getting so much actual sodium channel poisoning in the wrong conformational state.
Okay.
But anyway, that's another thing to just pull out. There's no great randomized control trial for this.
So this is distracting the bouncer, is what you're saying.
Yeah, exactly. I like that. That's good. And then you talk about other stuff, right? Then you talk about intralipids or intralipids or just lipid emulsion therapy. There's like lots of case reports. People do that. When to do it, we don't know. There's a lot of theories about how this works. Tell you, there's a lot of research being done on it. So that's just something else to consider. Again, I can't tell you that there's a great protocol or when to consider doing it. I'd say like if they're starting to get sick and you're throwing the kitchen sink at them, I think this is a totally reasonable thing to do.
Okay.
It's not without side effects, right? You can have fat emboli and pancreatitis and all kinds of other stuff. But it's if somebody's dying on you, right?
You do what you got to do.
You do what you got to do, exactly.
Now, lidocaine dosing is your standard dosing?
I'd have to look it up, but yeah, it's generally just kind of what you generally put the people on lidocaine drip on.
Okay.
And then finally, especially if you're at a tertiary care center, ECMO, right? So this is really, you think about it, this is cardiac poisoning, it's going to go away as soon as the drug goes away. And so what if you just took the heart offline or you didn't have to worry about it so much?
Right.
You could do ECMO for a bit, and then they can walk out of the hospital in a couple days. So I've seen this a fair number of times. We actually had one of these at Children's Hospital recently, where there was a TCA overdose, recurrent dysrhythmia, CPR, etc. And then so they decided to ECMO, and then she was on it for a couple of days, got weaned off, and then literally walked out of the hospital. So it's impressive, right? Where your heart is literally not working. We'll take care of that for you. We'll bypass the whole system until the offending agents are out of the system, and then we'll decannulate you, and you can, off to Psychtown or wherever you're going to go, right?
Right.
So those are the big things that I want to talk about with sodium channel blockade, right?
Awesome.
And I think this is a really good recent illustration of some good EKGs, the progression of the EKGs too, right? And what to do when you do see something like this. And so this is a not miss EKG. And again, another reason why just part of the general tox workup includes EKGs, and then observation of somebody to see which way they're going to go.
Okay. So again, as a recap, as we're looking at the EKG, what we're going to notice is this widening of the QRS, particularly in leads 1 through 3. And then as we look at AVR, we may see a prolongation of the R wave. And then, in like V5, you may see kind of a lazy repolarization out of the QRS, so between the QT, I guess you could call that. Is there a name for that?
Just
J point?
Oh, the lazy? No. Yeah, so remember, just when you're calculating the QRS, it's on the limb lead, so it's all these guys, right? And you don't calculate the QRS with the precordial leads, and then it's the elevation of the AVR, so it's the size of it, and so really 3 millimeters is what I start paying attention to. Or if it's it's usually isoelectric, honestly, so this is usually not elevated. So when you start seeing this get elevated, that's when you start paying attention. And then just the diffuse lazy terminal 40 milliseconds of the QRS complex is just gonna not be as chipper, as crisp.
There we go.
It's a good term.
Thank you, Dr. King.
And then treatment. Remember?
Yep.
Sodium bicarb, hot salts, lidocaine, intralipids, and ECMO. That's about the best we can do nowadays.
All right. To prevent that seizure, coma, death.
Exactly, and that's the whole point of when we do this, right?
That's right. All right. Thanks, Dr. King.
Thanks, John.